When it comes to health and care policy, decisions made today will have a profound and lasting impact on the future. Decisions like, how should we balance spending across health and social care? Should we spend more on preventing people from getting ill? What services will we need as our health needs change in the future? And what people and buildings should we be investing in now to deliver them? Health and social care leaders need reliable evidence of what their decisions may mean in the long term. That's why the Health Foundation is launching the Real Centre. Our independent analysis and projections will help identify future health and care needs and demonstrate how these will be affected by population change, patterns of disease and new technology. Our work will explore the impact that different decisions will have, all influenced by evidence of how policies have impacted in the past. We'll help make sure that today's decisions are grounded in facts and strong evidence, contributing to a more sustainable health and social care system and a healthier future population. To find out more, visit health.org.uk/real.
Good morning, everybody, and welcome to this webinar, which is to do with the launch of the Real Centre. We're absolutely delighted to be launching the Real Centre, and with this accompanying lecture that we will hear this morning. The Real Centre is the research and economic analysis for the long-term centre that the Health Foundation has funded. Why have we done it? You've just seen, hopefully, the animation, which explains a little bit about why we have funded such a centre. And our thinking is that the health service and social care, if you think about it, it's about £140 billion per year that is spent on these services. And yet, how often do we see a really good long-term analysis of the demand and supply factors that the health service and the social care system are facing, and therefore what resources are needed for the future? Too often, our analyses for spending reviews and so on are done within 3 or 4 months for an event like a spending review or some other event. And actually what this system needs, being the largest, certainly the NHS, the largest organisation in Europe, it really needs some much stronger basis for the planning of the resources that it needs into the future. By that I mean 25 to 30 years. So as a result of that, we decided, and also prompted by the Lords Commission on the Sustainability of the Health and Care System, we decided to invest in an independent centre that is really going to put this planning of resources on a much more quantitative and consistent and solid footing for the nation. And it is that we have launched yesterday with our report, our first report by the Real Centre, called The Bigger Picture, which I hope many of you have had a look at. And today, we're really thrilled to be able to have a lecture, which is the first real challenge lecture that is going to be given, the first of many, we hope, annually, given by Sir Andrew Dilnot, who I will introduce in a moment. So what we have this morning is we have an hour and a half. We are going to have Sir Andrew, who's going to be giving us his lecture. And then we're very thrilled to be joined by a panel where we'll have some immediate response from each of the panelists. I'm going to give them about 5 minutes each to have their initial response. And then we're going to have a discussion and bring in some of the questions that many of you have posted beforehand, which we were thrilled that you did. And we're going to have a very lively discussion about some of the very interesting issues that I know Andrew is going to raise, in part based on the report the Bigger Picture that we published yesterday. I forgot to introduce myself, of course. I'm Jennifer Dixon. I'm privileged to lead the Health Foundation, which is the organisation funding this new centre. So just some other housekeeping I'd like to say. The discussion that we have will be about 30 minutes and we'll hope to wrap up at about 11 o'clock. As I say, thank you for all your questions to date. For those of you who are Twitterati, you can tweet this morning's event, and it's #RealCentre. So I hope many of you will do that in the course of this morning. So with that in mind, it is now my enormous pleasure to turn to Sir Andrew Dilnot to give our first and inaugural Real Challenge lecture for today. Many of you know Sir Andrew. He's very famous, and we're thrilled to have him to kick the Real Centre off. Sir Andrew is the Warden of Nuffield College, Oxford. He also has, as you know, very illustrious history. At least a couple of things I will mention. One is that he was the director of the Institute for Fiscal Studies in the 1990s and really set off that institute to be the organisation, the valuable organisation it is today. And he was also chair of the UK Statistics Authority, and obviously had a very interesting perch to look at the way that data is collected and used across the UK, which is also clearly very relevant to the Real Centre. And he's also been master of many commissions looking at funding various parts of the public sector, as well as you will have heard his dulcet tones on Radio 4 in many a programme to do with numbers. So I'm truly delighted, Andrew, to be welcoming you to give our inaugural lecture, and I will hand you over to you now. Thank you.
Thank you, Jennifer, and thank you everybody for being here. It's great to be here. I'm really excited about the launch of this centre. I think it's an extraordinarily important thing that is being done by the Health Foundation. This matters a great deal. Why might we need the Real Centre? Surely we know all that we do, don't we? Well, no, I don't think we do know all that we need to know, nor do we discuss all that we need to discuss. Health and social care in this country, as in much of the world, are huge activities. And in many ways, this big thing is very beautiful. It does great things for us all, but it's not well understood. And we hugely lack long-term budgeting and long-term objectives. Too often we think of health, and I've been very guilty of this myself, it's just one great big lump. It's not one great big lump. It's much richer, more complex than that. So let's start with big. I've often said about numbers that the question one should always ask about a number is, well, is that a big number? And let's start not with health, but with private spending, things that individuals spend their own money on. We take money out of their own bank accounts, their own pockets, and buy things. So here are some examples of really large items of household spending in the UK: transport, housing, recreation and culture, food, restaurants, household goods, expressed as an average amount of spend per household. So you can see it at the top, transport at a bit more than £4,000 a year on average for each of the 27 million households in the UK. So these are the kinds of things that are really large parts of household budgets. Where does health fit in relative to that? Well, not surprisingly, because we made these slides, it's out on top. Health is much larger in terms of spend than any of these other big bits of our household budget. But of course, the thing about health in the UK is that we don't buy health as we go along. We don't take money out and spend it as individuals on the amount of health that we consume. We prepay for health through our tax system, through what's effectively a system of social insurance. We all pay taxes that pay for this healthcare, so that when and if we need healthcare, we don't pay at the point, we've already paid through an insurance mechanism. That's true of health. It's not, of course, true of social care at the moment. In health, what was described by Winston Churchill when he first got national insurance going in this country is the magic of averages is brought to the rescue of the millions. We make sure in health that if you're unfortunate enough to have a very high health need, you don't yourself have to pay for that health need. We all pay to look after all of us. So it's big. It's 10% or more of the economy, whether we're looking at money or employment. It's a really large slice of our national life. And of course, it's grown. This is a chart that just shows you in two different ways. This line shows real spending, so spending adjusted for inflation. It's grown massively in real terms from less than £20 billion in current day prices to roughly £150 billion over the life of the NHS, starting way back in the late 1940s. Or if we look at it in a different way, as a share of the economy, we see that it started off around 3% of national income. It's now between 7 and 8% of national income. This is a massive growth. As a consequence of that, health has become a steadily larger and larger part of the overall budget for public spending. So at outset, the health service was about 7.5% of total public spending. It's now creeping up towards 20%, 1/5 of all that the public sector does. That's been made possible partly by changes elsewhere. So defence, which way back in the late 1940s was 20% of public spending, has fallen down to about 5%. So one of the reasons we've been able to increase health spending has been reducing defence spending. But it's also the case that other things that we might think we care about a great deal have grown much less quickly than health. So education spending, which in the mid-1970s was quite a lot higher than health spending, is roughly the same level, if anything slightly lower as a share of total spending than it was then. Health has massively overtaken it. So it's clear that this is an activity that we really value. It's grown because we want it, and presumably we want it because we think it does really good things. Now, of course, health interventions are not the only thing that determines our health. We know that background features of our social and economic life also have an enormous impact. But even having said that, it's clear that the health service and health interventions are making a big difference to our lives. There are lots of bits of information I could show here, but let's just show one, which is how long we're living. So this line is the cohort born in 1905 and how many of them survived up to the age of 100. You can see that at the beginning of the last century, there was still very serious infant mortality. Very nearly 20% of that cohort had died by the time they reached 5. Then a certain amount of death, and then death accelerating quite rapidly into people's 60s, 70s and 80s. So that's the 1905 cohort. The 1930s cohort, so I was going to say our parents, but many of you are younger, my parents, much, much lower infant mortality, so a far smaller group died, and then actually the rate of death through adult life is slower. And that means that by the age of, say, 85, instead of only 20% of the cohort being alive, which was the position from the 1905 cohort, we've got nearly 40% of that cohort alive, and that includes my mum, and I'm very glad indeed that she's still alive. Of course, this cohort, the 1930 cohort, were born before the NHS was born. What happened next? Well, the 1955 cohort, the cohort born just after the NHS was born, again, a further significant reduction in infant mortality and a further slight levelling off of this line, so that we see by the time we're up here, and of course these are projections because this group haven't yet reached their 70s, a far larger proportion of them still alive. And this improvement is continuing. If you look at the 1980 cohort, a further reduction. Of course, it hasn't gone up by as much because it couldn't go up by as much. If it went up by as much as it did before, then we'd have more than 100% of the population alive, and that's something that even the NHS can't achieve. But it is still the case that we're making improvements, and we've made even further improvements in the 2005 cohort. So to say, there are lots of other ways we could show data that showed that we were making progress in health, recovery rates from a whole host of diseases. It is a great story, and it's not surprising that we want more of this. As an economy, we've grown richer, we want more. Well, if we'd wanted more, we've certainly got it. This is what's happened to NHS activity and funding over the last 20 years. So here we are in 2000, 2001. We've indexed activity and funding to 100 at that point. You can see that funding, which is this bluey-green line, has increased very dramatically. It's very nearly doubled, approximately doubled. Activity has followed that line pretty well. And in fact, in the last few years, as health funding has been squeezed, activity has grown a bit more quickly. So it looks like we've got some significant productivity gains. But if we look at both outputs and inputs in the form of money, outputs in the form of total health service activity, we see a really substantial increase, a doubling over 20 years. That's a massive change. And that's a change that is far greater than the increase in the population. Over this 20 years, it's true that the population of the UK has grown a bit, but not by an amount that in any way explains this growth in activity, this growth in outputs. So we've spent more and we've got more. And I confess that that's really been my model until relatively recently for how to think about healthcare. I've thought about it kind of like a big sphere, which we inflate with more money, and then it just grows in a regular way and we get more output. Of course, I've recognised that we desperately need long-term budgets, that we need to move away from the feast and famine that has shown spending sometimes level, sometimes rising very quickly, although on average rising at a particular rate, so that we can, rather than having an annual fight about the amounts of money involved, have something that allows longer term planning. But fundamentally, I thought the question was, how much money should we put in? And that, of course, is what the political and media discourse and debate and struggle is about. Those of you who can remember back to the early years of the Blair-Brown government will remember Gordon Brown's great triumph and trumpeting of his £40 billion, or was it £24 billion, or was it £3 billion a year or two, but focusing on putting a great deal of extra money into the NHS, or Jeremy Hunt's more recent £20 billion. So a model of the NHS is a single homogeneous lump. We put money in, stuff comes out, that's all we need to think about. I now think that's a completely inadequate way of thinking about it. And the launch report that came out yesterday and working alongside the team through these last few months has helped me at least understand that view I had is a much too narrow and overly simple view. Health is complex, just in the same way as transport or housing or food are. We need to know much more about the details of what's going on. It's not a sphere, it's not homogeneous, it's not expanding equally. It's actually an extraordinarily complicated shape, a polyhedron with all sorts of lumps and bumps, and it's changing its shape massively all the time. It's growing irregularly for many, many different reasons, and not always in a way that is terribly well planned, or where the outcomes are what we thought we were getting in the first place. Health is a complicated thing, and what the launch report, I think, shows is some of the ways in which that's true. So what I want to do is just go through a few of those forms of complexity so that we can think about where the decisions are made and what kinds of decisions should be made. Look at some of the things that come up out of the launch report. Let's begin with looking at the growth, the relative growth of different bits of the healthcare system over the last 20 years, which is detailed beautifully, I think, in the launch report. So here we've got some of the major items of healthcare activity, and there's more detail in the report. And this is the overall change over a period of 20 years. Remember that overall there's been a doubling, so we'd expect, if it had been uniform, we'd expect all of these bars to be at 100%. And as you can see, they're just not. Elective procedures have grown by almost 400% over this period, almost by a multiple of 5. Extraordinary change. Diagnostics, 200%. Outpatient appointments, more than 100%. And then down at the bottom, community services and GP consultations have grown by a great deal less than 50%. So we've seen a big shift towards this kind of activity largely going on hospitals and away from this kind of activity going on in the community and in primary care. But hang on, hasn't one of the main objectives of policy over the last 20 years been to move towards community care and towards primary care and not to focus entirely on hospitals? These are massive changes in composition, which at least I was not really aware of. Is this because of changes in the underlying structure of the population, was one of the questions that the team have asked. If we adjust for the size of the population, for age, for gender, for proximity to death, does that help us explain what's gone on here? Well, let's do that. That's how much change is explained by demographic change. So a little bit, and it varies a little bit across sectors, but it goes nowhere towards explaining this massive reorganisation, this massive restructuring. So what is driving the change, these big, big changes in this massive activity? Well, here's a very simple way of thinking about how healthcare activity, what's in the middle, gets determined. There's demand for healthcare from all of us. There's a supply of healthcare and funding from all of us. Because at the point of use we don't pay, we'd always expect demand to exceed supply, so we'd expect there to be a gap. That looks relatively straightforward, but of course we have to ask what's behind the demand. What are the things that determine demand? And there are lots of things determining demand. Demography, tastes, attitudes, incomes. And then on the supply side, it's not just the amount of money that determines supply. There's what's going on with technology. There's what kind of buildings we've got that we can rely on. Who's in the workforce, of course, where the funding comes from, and what's happening to costs. And then on top of all of that, determining demand and supply, we've got to put policy. Politicians and hospital managers, the chief executive of the NHS, there are an awful lot of people thinking about policy and making policy changes. There's a huge array of choices and decision makers who are, between them, making an enormous difference to what it is that the health service does. But all too often, I don't think it's very clear how those decisions are come to, and even whether they're being monitored, at least their outcomes are being monitored carefully enough to know whether we're getting what we really want. Let me give you some examples of just a few of these variables. Let's start off with costs, and all of this comes from the report. Again, look here over the last 10 years at what's happened to the annual rate of change in costs of different activities. So across A&E, costs have been rising by 5.3% a year. That's a pretty rapid increase. Outpatient appointments, an average increase of 1.1% a year. Diagnostic imaging has been getting cheaper as we've seen rapid technological progress. Planned procedures have been getting a bit cheaper. Non-elective inpatients are close to zero. Consultations in general practice have been getting cheaper. Community prescribing has also been getting cheaper. Community health services have been getting more expensive. Again, there's enormous dispersion here. And one of the things that I'm really excited about for the Real Centre is that in many areas of policy and what's happening in the world, looking at dispersion can give us enormous insight into what's really happening. Technology is changing all of the time in the way that we can do things. Look at the way that we've changed over a period of a decade, the way that we do a particular diagnostic procedure, so endoscopic examinations of the uterus. In 2007-8, some of these were done as ordinary elective cases, the bulk as day cases, and a relatively small proportion as outpatient procedures. Over the intervening decade, we've seen a huge increase in the numbers, but particularly noticeable is that we've seen a big increase in outpatient procedures, a reduction in the number of day cases, and an even bigger reduction in ordinary electives. So a huge shift towards being able to do this particular procedure and many others as an outpatient procedure. That changes what's possible and the costs. We have to think about people's behaviour. People's behaviour changes, and that has a big impact on demand. What this slide shows is for people starting at little children aged 0 to 4, 5 to 17-year-olds, 18 to 34-year-olds, people in the prime of their life, aged 55 to 64, and then older people. What's happened to attendance at major A&E departments by gender? So we have women in red, men in green. And the thing that really struck me about this, and which rather surprised me, is that boys and young men have become less likely to attend A&E. It looks as though either risk-taking behaviour has reduced, or the risk-taking has become so severe that they're not in a position to take themselves to an A&E. But really quite dramatic that amongst this group, who we would always have thought of as being the most likely to have accidents, there's actually been a reduction in attendance at A&E, whereas for everybody else, including the older population, an increase. We really need to take that kind of thing into account to understand why it's happening, and then also to take it into account when we're thinking about what to do next. Then another critical source of determinant of supply is what's happening in the workforce. And here again, there have been massive relative changes. So this is the year 2000, this is where we are now. GPs are this purple line, and they've increased a little bit, but not very much. Nurses is this green line. Similarly, they increased a bit, but not by very much. Hospital doctors have nearly doubled in this period. And so it should be no surprise to us that we've seen a big increase in elective procedures, in planned activity, because we've got a much, much larger workforce able to deliver that. And of course, much of that has been entirely deliberate. There was an intended outcome of bringing waiting lists down. But the change is huge and something that we should be alert to. And then finally, in terms of determinants of this change, our underlying health, or at least our identified underlying health. What this chart shows, starting in 2000 to 2001, going up to 2017-18, is what proportion of the older population, those aged 70 and over, have no long-term conditions. The answer to that was nearly 60% in 2000-2001, but only just over 30% in 2017-18. And then how many have one, two, or multiple conditions? And what you see over this quite short period, certainly in the history of humanity, is a massive increase in the number of people who have or are identified as having multiple conditions, so that treating some of these people here with multiple conditions, that's a really significant and complicated business. These are just attempts to show some of the kind of things that are underlying what the health service in this country ends up doing, underlying the enormous structural and compositional change that we've seen, which, as I say, I don't think is necessarily exactly what we'd wanted. We want this activity to be well understood. And if it's to be well understood and well planned, we have to be clear about its aims. It's not one big blob, and the change in composition that we've seen has been remarkable. To get the best out of this huge part of our lives, we need long-term planning. But that long-term planning just doesn't need just to be about the long-term budget. The budget is only one of the inputs, albeit a crucial one. We have to ask the question, what outputs do we want? What do we want to do with this very large slab of our activity? Are we trying to save lives at all cost? Are we keen to invest in prevention and public health? Is a key part of the task to be ready for shocks? Should we be focusing on chronic care or acute care, old people or young people, hospital care or care in the community, small GP practices or large, highly sophisticated primary care centres? Should we want more specialists or more generalists? And all of this is to say nothing about social care, which is also a vital part of how we look after one another. These are hard questions, and it's not obvious what the answers are, but that's where the real centre, I think, is going to come into its own. In health provision in the UK, there's a huge amount to celebrate, but there have been massive changes which I think have not been widely understood or even much known about, certainly by me, and possibly not even quite what was intended. We need, looking to the future, a long-term plan for funding, but that's just one of the inputs to health activity. We also have to have a clear view of what it is that we're trying to do. What are the outputs that we want, and why do we want them? The Real Centre and the analysis that's done there can help us understand what has happened and what we might expect will happen next unless policy is changed. All of that will be crucial context for thinking about what our objectives are, what it is that we want healthcare to do, And once we've done that, we can think about how those objectives might be achieved. And then, critically, we can go about checking to see whether they have been. We need a richer, better informed debate, accessible to the public and to politicians, asking what it is that we want and whether we're getting it. So let's all be part of a mission to understand what it is that we're doing now, think about what should happen next, and work on how that might be achieved. Let's help this big, beautiful thing be better understood, better planned, and even more effective. Thank you very much.
Thank you very much, Andrew, for those very cogent words and very interesting analysis based in part on the report published yesterday, The Bigger Picture. So Andrew's going to join me here now for the panel discussion. And before I bring the panel in, I just wanted to abuse my position as chair and just to have one comment. When you were speaking, it reminded me of a comment that Rudolf Klein had, an observation he had, which was up until the 1970s, between 48 and in the 70s, when that period of the NHS's existence, there was a sort of pact between the politicians and the medical profession in that the politicians were given the right to set the budget, and the docs were allowed to just do what they wanted with the money, and no one would ask questions of the other. And clearly that changed in the 70s with various efficiency programs and so on. And the noose has been tightening on the NHS ever since. But nevertheless, despite that, there is this lumpy growth, just as you describe. So I guess the question is, given this is such a ginormous amount of money that is spent by the British state, given that it's number one in the public set of concerns, how come, in your view, given where you've been sitting around the state for some years, why do you think that is? Is it just that the state likes to live from hand to mouth year to year, and doesn't believe in forward planning, doesn't have confidence in imposing some more rationality, or is there something deeper? Because the real centre will come up against this, won't it?
Sure. I mean, my guess is that probably the answer is lots of things. I suspect there isn't one answer. I think part of it is there is an inherent short-termism in government. And thinking about how we get multi-year budgets, I think, is a really critical part of all of this. You know, we go from year to year we tell the health service what its spending will be in years 1, 2, 3, 4, and 5. But actually in year 2, it's never what it was told it was going to be. And so there's an argument, a political horse trading every year about what's actually to be spent. So I think that's part of it. But I think there's a bigger thing. And I think perhaps two more big things. The first is that because healthcare is about risk pooling in this country, none of us is buying healthcare, and I'm so glad about that. I mean, it's wonderful that we have a social insurance-based system. But that means that there isn't a clear price in people's minds, or even necessarily in politicians' minds, for individual bits of the healthcare system, or even perhaps for all of it. So I think there's a challenge there. Then I think a second big thing is that most of us don't understand healthcare very well. We interact with it intermittently. When we do interact with it, it's incredibly important to us, and we see in high relief the bit we're interacting with, the GP or the hospital or the care home. But we don't have a really good picture. And one of the things I hope most from the work of the Real Centre is that we can get a better informed public, including politicians and the media, so that we can have a richer debate that rather than reflecting our own personal experiences, which are still important, can set those personal experiences in the context of recognising that overall healthcare output has doubled, but the area where it's increased most quickly by a massive distance is elective procedures, and primary care hasn't. So I think somehow to get a richer debate, we all need to find a language in which to speak about the detail of what's happening, because unless we understand more of the detail of what's happening, we're not going to get to objectives. And then perhaps one final point, some of the discussions we've got to have are uncomfortable. How should we spend the money? What should we really spend the money on? Requires us to face up to what we're giving high priority and what lower priority. And at the moment, I feel as though the political and media imperative is always to think that the most important thing is saving lives. It's easy to measure deaths, whether somebody's alive or not, but it may well be that also presses us towards the short term. It's not easy to think about how to think about those priorities.
Yes, and of course there are massive and different vested interests, of course, in the supply side of healthcare, which are pulling in also other directions. Good, thank you so much. So now, thank you for your forbearance, our lovely panel here. I'm very, very pleased to introduce the members. We have Raj Jain, who is the Chief Executive of the Northern Care Alliance. This is a collection of NHS trusts in the Northwest. And very pleased you could join us, Raj, giving us perhaps more of a local or regional perspective on why this kind of work would be helpful at the front line. We also have Wes Streeting, who is the Shadow Exchequer Secretary to the Treasury. That's a bit of a mouthful. And also the MP for Ilford North. Very pleased, thank you, Wes, for joining us and particularly giving us a political perspective that I know is going to be part of the discussion, judging from your questions. And then also we have our very own Director of the Real Centre, Anita Charlesworth from the Health Foundation, whose baby this is, it has to be said, and that's why she's looking so pleased this morning, because it's something she's always wanted to do. So wonderful, welcome all. So I'm going to invite each of you in turn, starting with Raj, just to give a few moments of reflection on the interesting words there by Andrew Dilnot.
Thanks, Jennifer. I would just like to bring to life, I guess, from the shop floor, some of the interactions and consequences of what we've just heard from Andrew. And really a bit about focusing on the need for long-term planning and overarching goals and standards over the long term for health and social care. And I was going to use two case studies, if that's okay, to try and bring this to life from that shop floor. And the focus areas I want to talk about very briefly are the misalignment of health and social care funding mechanisms, workforce planning and development, digital planning, and overall governance arrangements. And I'll do this very briefly. The first case study is an 81-year-old, fit and able, lives by himself and pretty well. He gets an infection, admitted to the acute unit. We find it's a urinary tract infection. Gets treated and discharged home, all pretty well. He gets discharged home with a care package. The first step of that care package is to remove a catheter. But we then find that 4 or 5 days later, a friend knocks around and finds him in his pajamas at home in a state of distress and dehydration and other things. And on investigation, we find that the first step, the removal of the catheter, didn't happen. As a consequence of that first step not happening, the next steps aren't triggered. Social care isn't triggered, and the wraparound isn't triggered around that individual. The issue that underpins this is the lack of information and intelligent scheduling that could happen today if we had taken a long-term view about how we invested in our digital infrastructure to enable all parties of that care package to understand what was happening with that patient and also to prompt when omissions happen. Numbers are really important on this. My organisation discharges about 100 people every single day. Errors occur. In some studies in Australia, it said that errors in processes of healthcare are run about 16%. Well, let's assume that there's 4%. That's 4 admissions, 4 discharges that go wrong every day. Consequence of misery on our patients, absolutely. But it probably has a cost to the health system of about 300k a week. Aren't insignificant things. So looking forward, if I had the magic wand, how would I address some of those things? I would really like to have national standards around our infrastructure that's needed to move information across our various systems. Distinctly lacking, and that leads to a fragmentation of standards at a local level where it's really difficult to connect systems and where we haven't got consistent planning to enable that man to have a good and effective wraparound care. If we had that long-term view, we could do our work much more effectively with say, the misery in that 300k per week. But we would also be able to take advantage of the rapid innovations in digital healthcare and social care packages that enables us to cope with some of the demands on our services in a much better way. Just very briefly on that overall one. Case study 2 is about a resident in a private nursing home. That resident needs diabetic care. And what happens at the moment is that the staff in the private resident home are very unlikely to have the skills to manage that diabetic patient. So a district nursing care service is called in from the NHS. The issue with that is that patient's treatment is fitted into the schedule of the district nurses as opposed to being titrated to the need of the patient. We're quite clunky in how we schedule ourselves, our needs, as opposed to what the patients need. And if you unpick this, you can see that if we had had a long-term approach, an aligned approach, where we did workforce planning and development on a consistent basis with alignment of health and care funding across the system, both private sector and NHS sector, we could get to a place where we have a single workforce development plan that enables those registered nurses in the nursing home to undertake that care. It's well within an RN's competence. It's just about training and the clinical supervision that needs to be wrapped around those staff, which can often be very difficult to get if you're in the private nursing sector. So joined up workforce planning is a critical part of this. Governance is a critical part of this as well. And my final statement would be about how is it that we do actually bring together people like that private nursing home with our services, where we have deep capacity and capability that just is not shared out amongst the system. Some significant blockages around the funding mechanisms to that, but also around the accountability or the governance mechanisms. Because at the end of the day, the private sector home wants to know who is responsible for that diabetic care if that diabetic care goes wrong. And at the moment, that's a really problematic question to answer. I'll stop there, Jennifer.
Thank you very much, Raj. I think those are really two very compelling examples. And perhaps if I can just ask you a question before I move on to the other panelists. You're in a very interesting part of the world because you're in Greater Manchester. And obviously 5 years ago, there was the Greater Manchester Devo deal. I think it was 6 billion, isn't it? And then the Transformation Fund on top. Albeit you are not given a budget for 5 years hence, but you are given more autonomy over that budget. So I just wondered, to what extent could the Devo experiment, if you like, in Greater Manchester that I know has made such progress, help with the kinds of things that you're saying, particularly planning infrastructure like digital?
Thanks, Jennifer. Just a clarification, we were given $500 million over 5 years against the 6 billion funding envelope. So it was insignificant, but it was not that large a cut. When you look at the annual spend that there is in GM, the advantage of GM devolution has really come about through the creation of really solid relationships between the local authority and the NHS. And in my organisation, we've been able to advance integrated care, i.e. working with our social care colleagues, our local authority colleagues in education, in housing and police, in a way that we wouldn't have been able to achieve if there wasn't that overall umbrella about integration in Greater Manchester. So we've shared some investment pots that's enabled us to address some of these issues, including partly that digital issue that I outlined. So we have a care package working in Salford, a digital care package that's able to bring social care and healthcare together. But we don't have that in Oldham, Rochdale and Bury, those other locations that my organisation covers. And the principal reason for that is about the long-term planning around digital, the long-term governance arrangements that directs funding through different silos into our landscapes, even with devolution. being in place, because it's not total devolution, it's
Yes.
some freedoms.
Yes, yes. Thank you for that. So I think we might return to the Devo issue because, of course, if national government has tin ears when it comes to planning, maybe there's more scope for, places like Greater Manchester that has a little bit more leeway. Thank you very much for that. Let's go on to Wes. Wes, you're our resident politician here, and what you can hear, I think, one theme coming out of all of this is the almost the lack of interest in the shape of the National Health Service beyond, the usual suite of policies that come out in a government's term of office, but particularly the long-term view of the NHS and the need for long-term planning. So I'd be very interested in your reflections, given your position.
Sure. I'm very happy to sort of provide a broad political perspective, though should caveat that with I'm not prepared to take all the flak for political failures by all political parties, because otherwise we'd be here all day discussing that. I'm thinking both with sort of my current hat on as a member of Labour's shadow Treasury team, but also before I was elected to Parliament, I was a cabinet member in public health for the London Borough of Redbridge when I was deputy leader of the council. I think as everyone taking part in today's session will know, the lack of long-term planning has bedeviled the NHS for years. And one of my frustrations, because I was in advance, I was asked to talk a little bit about the extent to which we can get long-term planning into the system. Frankly, if someone had told me as a cabinet member for public health that I had a 3-year funding cycle, that would feel long-term compared to where we are now. And I think, we should be thinking long-term over a series of decades rather than just a series of a few years. And I think that tells us how bad the starting point is. There are movements in the right direction in terms of providing longer-term funding frameworks for the NHS. But of course, we can't have a funding system for the NHS without one alongside it for social care. And what we really need is a long-term funding settlement that gives providers, staff working in services, people responsible for planning those services, delivering those services, but also people using those services, some sense of security about and certainty about the quality of care that they're going to receive over a longer period. And I think there's one thing the current crisis we're living through is exposed. It's the fundamental failure to plan effectively. And I think that's been particularly stark in social care, where so many of our care settings were dangerously and avoidably exposed because successive governments have ducked the difficult political questions that particularly Andrew and others have been confronting us with for some time. So I think in the sort of the immediate term, of course, there's a need for an immediate cash injection across health and social care. It is a constant source of frustration to me that the cost to the taxpayer of the current system is greater because we're moving further and further away from principles of early intervention. And we've seen that reflected in cuts to public health budgets. How much are we spending in hospitals, in acute settings, because we're not dealing with issues around frailty, for example, and people presenting with conditions that were entirely avoidable if we've got the funding and the care framework right. Clearly, a government with a majority of 80 doesn't need to build consensus on these issues. I mean, take social care, for example, where Boris Johnson has, I think, said pretty much everything all of his predecessors have said about the need to fix social care. He can fix it tomorrow, and he doesn't need to consult us. But the reason he should is that you would hope that when it comes to the fundamental pillars of the health and social care system, the pillars of delivery, funding, user experience, those really ought to be areas of consensus. You would hope that even if governments change and personalities come and go, that there are certain fundamentals of the system that are built on consensus to provide people with the certainty they need to plan and deliver effective services. So I hope the government will reach out in that spirit of cross-party consensus, particularly when it comes to fixing social care. And I hope that one of the things that can come out of the launch of this centre is I mean, I was thinking about this in the context of the OBR, actually. One of the things the Office of Budget Responsibility has done is confront politicians in the Treasury with the reality of the choices that are facing them and the country. And sometimes that's a more favourable outcome, sometimes it is a grim reality, but nonetheless it is a heavy dose of reality, and it's harder for politicians to duck the difficult decisions. Where is that in health and social care? Okay, when the going gets tough, Simon Stevens can pop up on the Today programme and tell us how many billions he needs. And when the going gets really tough, he can extract the money out of government. Who's doing that for social care? And who's confronting politicians whose cycles are naturally short-term, you know, most 5-year election cycles. But having said that, I've been an MP for 5 years and I've fought 3 elections. You know, we need someone who is confronting us with not just the short-term challenges, but the longer-term challenges, so that people can see in a more transparent way what's needed, but also the consequences of politicians ducking some of those difficult decisions. Some of this is very controversial, particularly from a Treasury perspective. The Treasury naturally doesn't like being bound into long-term commitments. But on this issue more than any other, health and social care, we have to move away from short-termism to long-termism, and we need to build the political consensus we need to break through some of those quite thorny political issues that, frankly, have cost successive prime ministers majorities at general elections.
Thank you. And just a very quick follow-up on that. So what practically would Labour be thinking about to try to put funding on a longer-term footing for the national... Let's just take the NHS for now.
Well, sure. I mean, we would absolutely accept the principle that there needs to be a longer-term funding settlement for the NHS. And as we think ahead, obviously we're years out from a general election, and we, you know, I have to say, as a shadow Treasury Minister, my default setting, we are programmed to say no to requests from shadow ministers and no to any commitments we would be binding our hands. But I think we absolutely accept the need to get to a point where we're able to make a longer term commitment, not just to health funding to the NHS, but to social care as well. And, you know, we've got people like Liz Kendall on the social care side in particular, banging this drum very hard from a very well-informed perspective, having worked on the policy issues of social care for many years. So I hope that that's by the next election where we will get to, and I hope certainly something that a future Labour government will be able to deliver.
Thank you so much. So now let me turn to Anita, my colleague. One thing I didn't tell you about Anita was that one of her former jobs was chief of the public sector team at the Treasury. So she knows all the arguments that the Treasury would employ to possibly block such a longer term view. Anita.
Yeah, and I thought, having heard from Raj what it's like and the impact on the front line and why this might be necessary, and from Wes about the sort of politics of this, I thought I'd look internationally. And I wanted to draw on some work that the OECD did, actually nearly a decade ago now, where it looked across its members at countries which had managed successfully to institute major structural reforms in the labour market, in pensions, and also in product markets for things like digital that Raj was talking about. And, you know, at the moment in particular, we've obviously for several years now been in a period coming out of 2008 financial crisis where experts, if you like, and expertise and evidence was discredited in much popular discourse, and there was quite a wave of populism that we've seen. And so what we're trying to do here is to try to support evidence-based policy making, and you might think that is a bit like pushing water uphill. But actually, when the OECD looked at the examples where countries had instituted major structural reforms, what they found was really quite interesting in terms of where countries have been successful. So sustained political leadership, consensus on the fundamentals that Wes talked about, really, really does matter. Yeah. And so we will be pushing water uphill if there isn't that context. Yeah. So, but also actually that is necessary, but it's not sufficient. And what they found was that in addition to that, what really mattered was a really good case for change, to explain to people why the status quo, why just letting things continue as they are, might not be desirable. There may well be negative consequences to that. But they also found that who provides the evidence and the nature of the evidence really matters to the ability to reform successfully. So where countries had really strong evidence bases, which were really analytically sound for the changes, and where that evidence had credibility because it came from independent and trusted voices, which is again the point about bodies like the OBR, like the IFS, then you were much more likely to succeed. So actually, we in the Real Centre are trying to help the senior decision makers and policy makers get one bit of that jigsaw of being able to do successful policy making, as the OECD talked about, and provide some of that robust evidence. And as Andrew showed in his lecture, actually the health service is much more complex than often we think. And I think one of the things that's quite interesting is what Raj was talking about. A lot of people assume it's a whole lot more joined up than it is. And that we're doing things like integrated workforce planning. And so they're not clamouring for it. It's a bit like one of the reasons why social care reform has got so stuck is because actually when you go out and you do work with the public, most of them assume it's a whole lot better than it is. And they don't understand. And so I think there isn't that accountability and pressure for reform often on these issues, because people assume that it's actually all happening at the moment. And I think one of the things you see from history, which is really, really important, is that we do need longer term funding settlements, absolutely. But we need that also in the context of real alignment and integration with other areas of work. So I'm going to draw there on a second study that the OECD did when it looked at healthcare systems across advanced economies. And it looked at which were more high performing and which were less high performing. And actually, when you looked across those systems, all of them aimed to deliver universal healthcare coverage. Yeah? It didn't find that there was one model of healthcare that was unambiguously better than another. Yeah. So in France, you have, and Germany, you have social insurance. In Sweden, like us, you have a tax-funded system, but more local tax. All of these systems, it didn't find one model worked better than another, as long as you have that principle where people are protected from catastrophic costs and it provides comprehensive cover. What they found, though, is countries differed really starkly in how well they managed their system, in that it wasn't some silver bullet individual policy. It was the actually really tedious detail of getting things like your workforce policy really well aligned with your funding, really well aligned with your digital strategy, well aligned with what you were trying to achieve and how you're regulating your system. Actually, this is heavy lifting work where you need to get all your ducks in a row. And it's that we have done less of. And I think this is important when you start to think of a Treasury perspective, because the Treasury has two roles. Bit of jargon here. It's a finance ministry. It worries about how much you're spending at any particular point in time, and do the books add up? Obviously, at the moment, they do not, but it does worry about that. And as Rishi Sunak said in his Conservative Party conference speak, he will be worrying about that again very soon. But it also has to be what's called an economics ministry. So one of the reasons that we've been struggling for a decade now, since the 2008 crash, is because our productivity growth as an economy has been absolutely sclerotic. And we've not grown enough, essentially, to come out of the after effects of that financial crisis as resiliently as we would need to be. But that the Treasury needs to think about its role, not just in balancing the books today, but how it actually achieves an economy that can grow and deliver our social objectives long term. That's what's called an economics ministry. And many of the sort of things that we've been talking about today are examples where too short-term a focus on the finance ministry has led us to have a system which is fundamentally less value for money in the long term and undermines that Treasury economics role. Yeah, and Raj's examples about where we're doing that, and essentially we're in the lose-lose of spending more money and delivering worse outcomes are real examples where an over-focus on your short-term cost control, driven by that finance ministry concern, undermines your economic ministry role. And as Andrew showed, the health service is a huge part of our economic activity. It's a huge part of public spending, and it's not going away. So we really do need to address to adopt more of an economics ministry focus, even within the Treasury. Thanks.
I think that's a really interesting point, isn't it? Because so many debates go on about, is the NHS sustainable? And actually a deeper question could be, how come the economy is not strong enough to power the health service that we all want and need, as is the case in other European countries, as we see. So thank you for that, Anita. There was a point one particular point you raised, which is clearly, and Andrew did as well, the Real Centre is going to develop a much stronger and sustained evidence base on which to understand the future, looking at the past and projecting forwards to the future. But you also talked about the need for consistent leadership along this pathway. So I guess the question there is, can the politicians deliver that, particularly across different governments? Because the NHS is here for the long term. Politicians and governments come and go. How do you have commitment devices to bind them to a consistent path, I suppose is the question. And if you can't, and I would direct this other question maybe to Wes, then this whole concept since 2012 of having a more arm's length leadership of the NHS, let's just keep to the NHS for a minute, from the political leadership through the Health and Social Care Act, having NHS England having some more agency, is that the way to get more commitment over the longer term? Or thirdly, is it actually through a more devolved agency in the way that we've just been discussing with Greater Manchester? So how do we, if we've got a more sustained evidence-based, how do we get more sustained leadership, whether it's political, national or regional, or indeed technical leadership from the NHS? Sorry, that's a big question and a long one. So who am I going to turn to? Let's turn to Wes first, I think, on that. Political, how do you bind in the politicians to a long-term view?
I was hoping you were going to give that one to Anita first. But I think you're right about, we've had strong objections to what the coalition government did in terms of, the big NHS reforms. But as you say, that arm's length leadership has been useful in that, as I described earlier, there are moments, and Simon Stephens chooses them well, but there are moments when that leadership can stand up as a trusted voice with the public, deliver some hard truths like to politicians, and ultimately extract, if not everything he wants, at least move the government in the right direction. And I think that's a model that has been successful. I'm not sure we should just give up yet on political consensus when it comes to sort of some of the big questions ahead, particularly around social care, because I remember when Andy Burnham and Gordon Brown were savaged by the Conservatives for threatening to introduce a death tax. That attack was not only so politically salient, it did for Labour in lots of respects, but David Cameron didn't forget it, which is why he didn't even go near the issue. And then only after he left office said, I really regret not doing social care reform. Theresa May put forward a bold, shall we say, offer in her manifesto. And that really was one of the big factors that cost her the 2017 general election. So I think, successive leaders of both of the main parties have found at their cost. But when you try to do this alone, and when you fail to build consensus around some of the big principles and big issues, there is a big political price. The public are grown up enough to recognise choices, and we just need to sort of level with them, but hopefully in a way that can bind us together. And some of these principles are fairly fundamental and shouldn't be contentious. Do you leave people on their own to share to take the burden of the cost and the risk, or do you pool resources and spread the risk? Do you leave the cost saddled with one generation, or do you make this a multi-generational commitment to helping to contribute to the cost of the service. And if you agree with that multi-generational approach, there are some difficult choices, but once you've got the principle established, I think the public can kind of go with it. And also recognising that this isn't just a sort of multi-generationalist in terms of young versus old. I mean, on social care, we've got huge numbers of people who are recipients of social care, who are working age, disabled people. They're about a third of the social care users. They're about half of the cost of the system. So this isn't quite as binary as sometimes the issue is presented. And so once you start to move into that evidence base, once you go back to first principles, you can start to put together the fundamental building blocks of a system that could attract cross-party consensus, public support, and consistency across governments and across decades. That's where we need to get to when thinking about the health and social care system as a whole. We've not given up on that. We have a limited amount of agency as an opposition. But I think even with a majority of 80, I think Boris Johnson might want to reflect on recent political history over the last decade and a bit more, and reflect on the fact that it's probably in his short to medium term political interest, as well as the national interest, to try and build a consensus on the issue of how we put together a health and social care system fit for the future.
I seem to remember Boris Johnson on the steps of London 10 saying, well, I'm going to fix social care once and for all. So let's hope he... Can I just turn to Andrew here about, just again, sustained commitment over time? I mean, where you see this in the private sector, because companies, you can say, it could be relatively short term, you see it very fully in the energy sector, where there's huge infrastructure costs. You can't just think 1 or 2 years ahead. We have something which is called the Infrastructure Commission, or we did have, I don't know whether it's still, So we have had to think about big public assets for the long term. And I just wondered if there were any lessons that you can think of from that kind of approach that could be applicable here to the National Health Service with respect to political commitment.
So I think there are. I think there are two things that we probably need. One is we need some structures within which the long term becomes real. So if we have long-term planning, we've got somehow to get some long-term budgeting so that the people running the health system can genuinely believe that if they do something that has benefits in the long run, they will see some budgetary benefit from that. So we somehow have to tie the multi-years together, and that's difficult in the public sector. But the other thing that I think is essential, and I think the thing that struck me much more thinking about this over the last 6 months and seeing the great work the team have done, is to do that, we have to know what it is that we're trying to achieve. So the National Infrastructure Commission has a pretty clear set of objectives, and it's working across many areas, but it has a clear and well-defined set of objectives. For us to be able to do multi-year planning and budgeting and operations in health, we have to know what it is that we're supposed to be trying to do. We have to know whether we are trying to move more towards care in the community and at primary level, or whether we're trying to focus on specialisms in hospitals. We have to make those decisions, which I think are quite uncomfortable but essential. Because unless we have a clear set of objectives, we're not going to be able to achieve them in the short or the long run. And I think that's a really big challenge. I think we can help with the long-term planning and the backup through organisations like the Real Centre. I think it is worth thinking about some of the comparisons with organisations like the Office of Budget Responsibility, the Bank of England. I think to the extent that we can create trust in the background material, we can help with the policy making. But the policy making has to be not just about budgets, but about objectives. And there, I think, we're still all at sea.
Yes, it's true, because the Real Centre won't obviously be addressing that. That's something for government, isn't it?
Well,
and indeed for the NHS itself.
Government has to make the decisions,
yeah.
But I think the Real Centre can help by saying, well, look, the objective might be A, B, C or D. If the objective is A, this is an effective way of achieving it. If the objective is B, this is an effective way of achieving it. So I think back, there's too much autobiography, isn't there, and everything, but I think back to my time at the IFS, 20 hugely enjoyable years. And I think what we thought we were trying to do at the IFS was set just that context, not say what government tax policy should be or what government social security policy should be, but if your objective is to have a tax system that is more progressive or that encourages investment, these are effective ways of doing it, these are not. And I think slowly over the last few decades, we have got a better informed debate about many economic public policy issues. And I hope that what the Real Centre can do is contribute to that in this huge area of health, so that people understand more the role of workforce planning, the role of the balance between primary and secondary and tertiary care, the interactions between health and social care. There's so much richness in information that can help us in deciding what the objectives are. The Real Centre can't in the end decide what those objectives should be, but it can say, these are the range of objectives you might have, these are where those objectives might clash with one another, and this is how you might achieve them. And that will be a great step forward.
Yes. I mean, one of the ironies of the report yesterday that you showed, which is the differential spend in the hospital sector and the primary care sector, I wonder how many at the top of the NHS and indeed in government would have recognised that, would have known that. And the irony being, I'm sure Raj and Anita and certainly I, having knocked around healthcare for rather a few more decades than we'd like to admit, can only just point to the number of ministers, the number of successive governments who've had as a key objective to shift care out of hospital into the community. And despite that, we see the graph that you showed. So something very powerful is afoot to stop even consistently articulated political objectives, which aren't really party political objectives. Yeah. So the question there is, what is at play here? What forces are causing some of this extreme lumpiness that you described that have skewed some of the investments? And some of that may be very uncomfortable. So Raj, I was going to turn to you because I know you've been very active trying to push care into the community, and you might see this much more at a local level.
Thanks, Jennifer. Just to bring that statistic alive about the inequity in expenditure between the acute and primary care, I spend more in my outpatient departments than the entire primary care budget. And when you say that, people don't believe you. It is a fact. Where I go with this is the hope, I guess, that a centre like the Real Centre can enable us to have a much more informed conversation at our local level with our local politicians and with local people. Because what we can't continue is to grow our A&E department with that increase in unit costs that Andrew displayed earlier on. The only way to that is what's happening now. I'm continuing to grow my urgent care system, my A&E departments, other than when we've been able to achieve a really good consensus of opinion with local politicians, local GPs, and members of the community to do something different about urgent care. And that's taken years to do. And so I'm really proud to say that in Salford, we have bent the curve on urgent care admissions to A&E, but it took us years to do that. And it took us, in the absence of having an evidence base of being able to present to local politicians and local people about the impact of what could happen if we were to change the way the investment profile of hospital versus community services. So I think that the relative independence of that intelligence and that analysis is hugely important. But I really support what Anita said earlier on. And then it's got to be localised, because I think that local discourse is key to changing this dynamic that we have in health services about bringing everything into the acute.
Thank you. I mean, it's very compelling, isn't it, that when people think about the National Health Service, they think of the role of rescue, they think of emergency care, they think of the TV with the doctors and the nurses in the ICU. And that's been brought to the fore with the pandemic, hasn't it? So I guess the question is how to maintain the focus on community care out with that gravitational pull. And that gravitational pull isn't just coming from doctors and nurses and maybe even politicians. It's also coming from the nature of the medical profession and where it finds its value and its excitement. Because underneath some of Andrew's figures is also the picture of specialisation and subspecialisation that's happened over the last 20 years that probably no one ever planned, which has probably skewed investment towards high-end treatments, also fueled by the science investment, R&D investment, which is also prioritised through the industrial strategy, of course. So the question there is to, I suppose, for the Real Centre, and I'm going to turn to Anita now, is how to understand where that gravitational pull of costs growth occurs, which is underpinning some of the figures that Andrew saw, and probably the vested interests of some of those that are not aligned with population need. So Anita.
Yeah, I think this is a really important set of issues, Jennifer, because so much of the debate about the pressures on the NHS, and I'm as guilty as anyone of this, very much focus on a lot of the demand side things that we classically talk about, the ageing of the population, increasingly, proximity to death. Perhaps we talk about different patterns of disease. All of those things do matter, and we could do much better at understanding those. But I think it's increasingly clear from the work we've been doing and others that a lot of those more, in economics speak, supply side factors, the decisions that we take about who we train, what skills they come to the health service with, the types of facilities and infrastructure that we build, where we invest our R&D and our know-how in, how much emphasis we put on, for example, buildings versus digital. All these things which we make as piecemeal decisions, often quite difficult to really clearly establish the kind of where those decisions ever were strategically planned. I did try and look at back at some of those, and historically it's quite difficult to work out where some of those were strategically planned. Certainly not thought about in an integrated way, yeah, or all thought about from their own logic. It's not that people are kind of not thinking about things in careful and important ways. So the industrial strategy, the future of our science base is thought about really intelligently by a lot of people. It's just not very well joined up with some of the other things that we're thinking about. And I think that that alignment that I talked about from the OECD is probably one of the most important things. And in particular, us shifting our focus to think how important some of those upstream decisions are that often we take without a lot of scrutiny publicly are to what we end up with. And this is where I think the Real Centre can potentially add value, because it won't be that there isn't a right answer to those questions. There are a range of choices. But at the moment, we're making those choices often implicitly and out of view of the consequences. And what we want to help is to make those choices more explicitly and to make them really cognizant of their implications or the nature of the service and the type of healthcare we're going to be providing in the long term, and what that means for people. And this does come back a little bit to then also what the OECD was saying. So, we need obviously political leadership, but bodies like us have a role to play to create the space for that leadership to occur. And in order for that to happen, we need to really articulate well the evidence-based case for change and the choices that are available. And I've seen, I've been involved in non-executive roles in the NHS for several years. And in some cases locally, that case is made really carefully after years of careful work with the public, with senior decision makers, with really understanding the evidence. And you can take people with you then. But actually, you see quite often people attempt some of those changes without that. And actually, you have to say that they then get stuck. And the public have a lot of legitimacy to that. The case was not paid. They see what they're losing. They don't see, and it's not clearly demonstrated what they're gaining. And it's the public's NHS. We don't have a right to make those changes unless we can really articulate that they will deliver real benefit to people locally and nationally.
Yes, I mean, there's a kind of underlying meme here, which is that you want to fund advances, and the best way of funding advances is to be loose in your approach, because innovation can happen anywhere. You don't want to constrain the innovators or the scientists. Just give good people money and they will find things. If you start imposing things, it will kill progress. And on the other hand, the caricature is, no, you've got to plan a lot more and you've got to be much stronger. So the question is here about the balance, isn't it? Because a lot of innovation that's funded, particularly in the medical side, is really the kind of the loose view of the world, that the best inventions come from not imposing any themes or priorities. So the question is the right kind of balance. And I guess, Wes, from your view, how much appetite would a Labour government, do you think, on being, where is it on this spectrum? How much, given the fact we need innovation to progress, how far is it prepared to tighten up with themes that perhaps of investment that the NHS and social care system may need to move forwards? So to direct funds maybe not towards some areas of science, but to others that may be productivity enhancing, for example.
Yeah, and I think this is a classic, but I have to be careful what I say here because I'm sort of veering very much into sort of John Ashworth territory and the sort of the natural sort of treasury sort of bean counter starts to kick in as well in terms of thinking, you start talking about sort of the productivity enhancing gains and, the sort of the lights start flashing and you think about the UK's overall productivity challenge, the extent to which health and social care is such a big part of our economy and where productivity gains in this space would make a real difference to the overall economic picture. So all of my treasury instincts say, absolutely that's where the sort of the focus should be directed. Sort of balancing that off against the overall health priorities, though, I just think as a general point of principle, particularly when you've got a system which is as large and complex as this, having that clear leadership from the top is really important. And that's very different from someone sat in at the top of a government department pulling levers and trying to micromanage and direct. It is simply about saying at a very top level, these are the priorities of the government. These are the issues, these are the priorities and areas that we think would best serve the public interest. And we are giving you, this very vast and diverse workforce, that leadership from the top in order that you can plan and deliver the services that work towards those goals and aims. And I think this is a problem that's plagued successive governments, but I think is a particular challenge sometimes for the character of Labour governments and sometimes what can be centralising and status instincts of our politics, which is a belief that if you want to get the right outcomes for the public, you need a minister, a secretary of state at the top issuing quite detailed commands to people working on the front line. I really don't think that works. I think there is no point in having a professional workforce, experts in their field, people who are frontline practitioners being told how to do their jobs by elected politicians or civil servants with good intentions in Whitehall, but not necessarily that practical experience. But that's why the thematic leadership is important. But ultimately, I think the whole thrust of government has got to be about transferring power out of Whitehall into communities and into people who really understand the public services they're delivering, the communities they're serving. But they just need to know the goals that they're working to. I think that's the sort of balance we need to strike.
Thank you. That's a relief to hear, I think we'd all say. Thank you. I just want to turn to another theme of questions that some of our audience have put forwards, and they're obviously on workforce, which we have touched on a little bit. I know there's a lot to be said, and I noticed some of the work Anita has produced, actually, which wasn't shown today, is some stark figures about the proportion of the workforce that is trained internationally. I mean, we obviously very much welcome in the NHS international doctors and nurses, for example, and other clinical professionals. But the proportion of individuals trained abroad is phenomenally high. So the question there is, did we plan that? Did we notice? What do we think about that? Is there something about having more domestic? Anyway, big issues about workforce. It is obviously the biggest cost item, if you like, in the National Health Service. And it's also very relevant to how we use the workforce better in future if this is a scarce commodity, and indeed how technology can help to restructure the workforce where that is helpful for sustaining the National Health Service. And just on that, before I turn to Anita and Raj, particularly on the workforce side, just looking at the industrial strategy, I think is an excellent strategy. There isn't really a strong theme in there which one could have imposed, which is really looking at the intersection of technology and the workforce to increase sustainability of one of our biggest assets in the country, which is the National Health Service, which you would think would be there. It's mostly it has other aims. So that's a case in point where there hasn't been that theme imposed. So Anita, I wanted to ask you a little bit more about the workforce. And there was a question someone has asked, which is, what has prevented this kind of demand and supply modelling for workforce in the past, and how might these barriers be broken?
Well, I think there's a difference between having an open workforce and an NHS that really welcomes people from other countries. It is part of a global community where people spend time in other countries, learning from other systems, sharing knowledge. And that's part of that vibrant culture of innovation and knowledge exchange. And a society that just systematically undertrains. Yeah? So we rely permanently on taking staff who cost a lot to train from other countries who invested in that training. And so we have systematically undertrained for decades and decades nurses and doctors, and we've got away with that from the get out of jail free card, which is our ability to recruit internationally because we've been an attractive place to come. I think that has been a false economy and a classic example of finance ministry put above economics ministry. I mean, one of the worst decisions that has been taken over recent years was the decision to reduce nurse training places earlier in 2011-12, to save a bit of cost in the short term, and ended up with a ballooning agency bill. Now, I mean, just a classic example of the complete difference between short-term cost cutting and longer-term efficiency. And also an example where cost cutting, essentially efficiency and quality of care went together. We need to get away from this fear of the cost of training and see the cost of not training people and make that much easier. So I think there is now actually the dynamics are changing as well. There's a global shortage, for example, of nursing. Thankfully the world has set itself an objective of universal healthcare coverage through the Sustainable Development Goals. Countries are trying across the globe rapidly to implement that. That is fueling a huge increase in the demand for trained clinical staff, and actually across the globe the supply is struggling to keep pace. So I think it would also be not only a wrong approach to continue to rely on that, but also actually probably an ineffective approach, and at some point you can never quite tell why, we would struggle to recruit. So why has that happened? I think it has been too easy always for each government, because it has been possible to recruit overseas, and we've always recruited really good quality staff who've made a phenomenal contribution to our NHS. And I'm not arguing for a closed system at all, but I am arguing for one where net over the long term, we contribute commensurate with our size and our wealth to the global pool of qualified clinical staff.
That's fantastic.
And I think the world is turning on that. I think more people see that now. Yes. And the polling would suggest that one of the things that people think is most wrong with the NHS is that we don't have enough doctors and nurses and we don't train enough. And they're right.
Yes, thank you so much. We are unfortunately coming to the end of our webinar now, and I really want to thank the panel very much, all of you. We could have gone on, and indeed Andrew, we could have gone on for some time, because there are just so many rich themes here, aren't they? And they are so difficult. But what's so encouraging, I think, is that the Real Centre can at least get some part of it right by at least providing the factual basis on which decisions can be made. And also there's probably, as I think Raj was saying, there's probably a bit of a communications job with how cute we can be, not just beaming this message to government and whether it's national or regional, Raj, but also to the public to try and change the weather of the conversation. We are hooked on emergency care, aren't we? And and the here and now. So is there something that we can do here to try to change the weather, or is that too much for the Real Centre to lift by itself? That's a question we will come back to. So it remains for me to thank very, very much Sir Andrew in particular for kicking off the Real Centre through the Real Challenge lecture in such style and with such a potent set of slides and arguments. Thank you. And to our wonderful panellists, to Wes Streeting, to Raj Jain and to Anita Charlesworth, who continues to beam and looking very happy because of her Real Centre role. I hope that's whetted for you, those of you who are sitting in your virtual environment, I hope that's whetted your appetite for a lot more information about the Real Centre and what it does. And I hope you'll stick with us in future to look at our products and reports and to look at the events and to join us in future and be part of the conversation. For those of you interested, there's a lot more interesting information about the Real Centre on our website. Sign up to our newsletter and you can get regular pulsed news for not just the Real Centre, but also many other things that the Health Foundation does. And before I sign off, I also just meant to say, because I forgot to mention earlier, that Sir Andrew, we are so happy to have bagged him to be the chair of our steering group for the Real Centre. So he'll be with us into the future as well as we steer this fantastic resource for the nation. Thank you very much. Many thanks for all your attention, for all your questions, for sticking with it, and for joining this very important conversation this morning. Thank you.